Hello, everyone. We're going to give folks a few more minutes, so please sit tight and we'll get started in just a couple minutes. Good afternoon, everyone. Welcome to Moving Forward Together, an update on building and measuring a culture of health. Just a few notes before we get started. So you know this webinar is being recorded and the video will be posted on our website shortly after the webinar. Please use the chat function in your Ring Central window to ask questions. You can ask them at any time. We will actually have a period for Q&A after the panelists present. So anytime you have a question, just use that chat function and don't use the raise your hand function. I would now like to turn it over to Carolyn Miller, Senior Program Officer here at RWJF, who's going to get us started.
Thanks, Nicole. So good afternoon or morning to those on the West Coast. Thank you all for joining us for this webinar. I'm joined today by, in addition to Nicole, my colleagues Margaret Tate from RWJF and Anita Chandra from the RAND Corporation. The three of us have been working alongside others at RWJF and at RAND for the last few years on defining, operationalizing, and figuring out how to measure a culture of health. So here's what we'll cover today. I'm going to start off by providing a little background about the Culture of Health vision, how the Foundation came to this vision, and the development of the action framework. Anita will walk you through a review of the action framework and the newly refined national measures. And Margaret will wrap up with some reflections of what we've learned over the last few years, some ideas and examples of how different groups might use the action framework, and some thoughts about what progress might look like as we build a culture of health. And we'll try to leave lots of time at the end for questions. So about 4 years ago, we introduced our new vision, where we as a nation strive to build a culture of health, enabling all in our diverse society to lead healthier lives now and for generations to come. There were numerous internal and external trends that led us to this new vision. In 2013, we supported the Commission to Build a Healthier America, and the Commission included individuals from the public and private sectors who were tasked with thinking about better ways to improve health in the U.S. in an environment in which health improvement was not happening fast enough, and there were new models emerging with a broader view about the production of health. Now, 3 recommendations resulted from this work. Invest in the foundations of lifelong physical and mental well-being in our youngest children, create communities that foster health-promoting behaviors, broaden healthcare to promote health outside of the medical system. This work propelled a shift from thinking about health just as healthcare to thinking about creating a more holistic view of health and the drivers of health, about creating a culture of health. We recognize that working on separate problems within fragmented and siloed health and healthcare systems wasn't producing the improvements in health and health equity that the country needed. Now, health will always be linked to healthcare, of course, but we're also beginning to acknowledge that it's influenced by social factors, like how safe our neighborhoods are, how strong and supportive our families are, and how invested we are in our communities. People's health has a lot to do with the individual decisions they make, that's for sure, but the choices that we make are based on the choices we have. Nearly 1/5 of all Americans live in low-income neighborhoods that make it hard to be healthy, places with inadequate housing, high crime rates, pollution, lack of job opportunities, and little access to nutritious food. So we recognize that we must embrace a more integrated, comprehensive approach to health. So in this context of health improvement not happening fast enough and new models emerging that embraced a more holistic view of health and well-being, we set out this vision to build a culture of health. But we knew we needed to do more to flesh out this vision if we were going to be able to really catalyze action towards this vision. So we partnered with RAND to help us define, operationalize, and measure this new vision. We developed the Culture of Health Action Framework, a set of national measures to help us track the nation's progress, and we began the work to integrate this work and inspire national action toward improving health and well-being for all. Now, we hope this work will catalyze new conversations about health and the culture around it, help us to develop new thinking about investments in health and well-being, and change the data structures and the systems around what's measured and what's tracked. Now, we've said all along that this is a long-term commitment, a generational effort, 20 years or so. So here's a brief timeline of the process of 2014. As I said, we began our collaboration with RAND Corporation back in the summer of 2017. We introduced the action framework in our initial set of 41 national measures at APHA in the fall of 2015. In spring 2016, we began the Sentinel Community Surveillance Project, which I'll talk about in just a minute. And then in the summer of 2016, we began an overarching evaluation of this work through our Culture of Health Progress Report, which will be posted on the Culture of Health website soon. And this progress report is helping us to evaluate the uptake and the understanding of this vision, of the action framework, and of the measures. Then in the fall of 2016, the Health Affairs special issue on Culture of Health was released. And about a year ago, we began to really look at the measures and refine our 41 national measures. And we'll talk today about the new set of refined measures that we've gotten to down to 35. And we've released those national measures now. Now, just a brief mention of the Sentinel Community Surveillance Project, which you see here on the timeline, which began in the spring of 2016. As we've said, the action framework and the 41 national measures particularly are a national set of measures. Those measures will help us track the nation's progress in building a culture of health. But we all know that health, the production of health, is very important in local context. It's very important to look at local context. So we selected 30 diverse communities from across the country to observe and watch for 5 years or so to see how they're moving along in their own journeys to build a culture of health. And these communities are part of a surveillance project. We aren't intentionally putting in programmatic interventions or funding. We're observing them, and we're writing reports, doing some primary data collection and as well as secondary data collection. And we're tracking their progress as they move along in a journey to build a culture of health. And you can find the 30 communities and the initial reports about those 30 communities also on cultureofhealth.org. So since we released the action framework and the measures in 2015, we've been getting feedback and listening to grantees, partners, and stakeholders. And we've learned a lot. We've learned that this framework and the measures resonate with many people. And we've also learned about different groups that are using the framework to organize their own thinking and their efforts to chart improvement and health. Now, for many, the action framework in particular provides an entry point and a way of organizing around health and well-being. And that's been the case in the conversations we've had with the Columbia Gorge Health Council. They were a 2016 Culture of Health Prize winner, and they're working with the action framework to really organize the great work that they're doing in that community. We've also heard from the Memphis Business Group on Health, which is a CEO Culture of Health initiative to create and encourage Memphis area employers to support health of their employees and their families through a variety of efforts. In this listening effort, as we've been listening to these different groups that we encounter, we've also learned that there's a need for us to clarify more about how the framework could be used by others and about how the framework informs the work of the foundation. And we know and have said from the beginning that we can't build a culture of health alone. And the foundation isn't working in every area or every measure area of the Culture of Health Action Framework. We're working in certain areas, and as we develop more of our strategies, our particular strategies around our programmatic work, we'll provide more clarity around the strategies and how they're aligned with the Culture of Health Action Framework. And then, so we also knew after we put out the Culture of Health Action Framework and the 41 national measures that we would be listening, gaining feedback, learning from people who were using the framework or trying to use the framework. We'd be refining those measures, collaborating with others, starting new partnerships to build a culture of health. And as we've moved along since our initial release, our commitment remains to investing in building this evidence base around a culture of health, and also to really looking at the system changes that need to happen in order to promote health and well-being across sectors within communities. And also then providing this evidence-based information and data to the decision makers to inform the strategies and the policies that are advancing more collaboration and the promotion of health and well-being for all. So now I'm going to turn it over to Anita, who's going to take us through a refresher on the framework and on the measures, and walk you through some of the new measures that we've come up with and what our new set of, our refined set of measures look like.
Great, thanks, Carolyn. This is Anita Chandra from the RAND Corporation, and we've been working closely with the foundation on building out some of the elements of the action framework and of the measures, particularly some of the refined and newer measures that I'm going to share today on behalf of the team. I'm going to ask my colleagues to help me advance, but I want to start first with the action framework as a reminder for some and perhaps new for others, which we hope is a good introduction. So as Carolyn shared, the team has been working for several years now with stakeholders around the country to help to define and operationalize what it really means to meet a vision of building a culture of health in America. And this action framework that you see here represents the core components of this operationalization. So first and foremost, this framework is organized around 4 action areas. These are areas that we identified based on stakeholder input, literature review, and other analyses of where the country needs to go as areas of continued action and investment in order to improve along a wide variety of health and well-being indicators. And I'll talk about each of these action areas just briefly to reorient folks. So the first action area, which is often considered one of the unique features of this action framework and really speaks to the values and priority orientation of a culture of health, is an action area on making health a shared value. This is the idea of appreciating that we're all in this together and that we have to start connecting elements of individual health, community health, and the role of institutions in supporting health, valuing health, and putting it as a priority in mission areas above and beyond just the public health department or the hospital or traditional health sector. The second action area is very much connected to the first action area, which is about fostering cross-sector collaboration to improve well-being. And this is principally to improve and enhance partnerships that support health and well-being. Now, we've been doing that for some time in health, but what is unique about this particular action area is a focus on more close integration of non-traditional health leaders, that is business community, faith-based organizations, nonprofit, social service agencies, and the like, and their role in supporting and developing and promoting and incentivizing health and well-being in their institutions and practices, and how to bring those mostly in closer focus around policies that will sustain their role in fostering that collaboration over time. The third action area is really about the built physical, social, and economic environment that we know from social determinants of health thinking is really critical for driving and determining not only investments in health, but improving health outcomes overall. This particular action area focuses on those domains, but also gives a specific nod to the policies and governance structure that supports healthier environments that can promote health over time. And then finally, it's important to continue to focus on what we're doing in health services and health services delivery. But in addition to strengthening the more traditional parts of medical and clinical care, how do we balance and integrate and strengthen the supports that are coming from social services and public health to really inform that more nuanced and complete picture of all of the elements that support stronger and more effective health services? All of these action areas then conspire to work effectively to improve population health, but not simply traditional healthcare outcomes or cost outcomes, but also aspects that support thriving and flourishing of populations, or in short, improve population well-being. And finally, the foundation has been closely committed for several years, looking at issues around health equity. How do we improve access and fairness and justice in terms of not only health services, but all of the features and conditions of a community that support health and well-being across the lifespan? And so that's why equity is in that central diagonal of population health, well-being, and equity, but also in the ring around it because it permeates and integrates across all four action areas. Next slide. So taking this together, and certainly the action framework is the operational nuts and bolts of culture of health, we wanted to represent this through a definition that encapsulates what is unique and what is different and what is forward-leaning about a culture of health. And this is the shorter definition that the team devised. A culture of health exists when individuals, communities, and organizations prioritize and promote enhanced well-being for all and value health as fundamental to the nation's social and economic future. I want to point out a couple features of this definition which make it unique from other health activities to date. One is an express focus on values, and this really speaks to the prioritization and the promotion of health, which is very much in the making health a shared value action area. Without understanding cultural orientation to health and well-being, we'll not be able to motivate individuals and communities to advance and promote health in the future. The second feature of this definition that's important is that we were trying to link more closely the issues of improved health and well-being as a nation, as a set of communities, not simply for improving health, which is important, but as critical to improving the nation's social and economic future. Health is critical for future wealth and prosperity, for innovation and productivity, and the future at all levels of social and economic security for the country. And that's a critical underpinning that we hope also invites other sectors to be more part of the culture of health activities going forward. Next slide. So as a reminder for some, if you've read the first or even the second, the newer report, we had a very robust process of selecting the national measures, and they had to meet a wide variety of criteria. First and foremost, we wanted to represent the action areas of the framework that I just described, within which we had 3 drivers per action area that really speak to investment and activities that need to progress in order to make progress. But we also had other criteria that we needed to represent in this list. First, and many of you have done measurement work can attest to this, they had to have data that are currently available at the national level, which is certainly easier said than done. But we worked with a wide variety of partners representing many organizations, inclusive but not limited to government, including the private sector and other organizations, that were gathering really robust, interesting national data that could speak to the action areas and the drivers within those action areas. We also wanted to represent measures that captured and assessed things not only across the lifespan from birth to the periods of aging, but also to represent the health span, all of the component pieces that we know drive health, clinical, medical services, but also social and economic drivers of health. We wanted to represent upstream and downstream drivers and determinants. That was critical as a forward-leaning framework that really focused on health promotion across the lifespan. And it had to really appeal to multiple audiences. And this was important not simply for shaping the narrative about health in the future, but also in terms of inviting a wide variety of sectors to be engaged in the process of seeing themselves in a culture of health. We wanted people to recognize their role and their value and their responsibility in advancing health. And finally, there had to be some component of these measures that spoke to issues of equity in terms of access, in terms of disparity, in terms of fairness, and some of the critical elements of health equity. Next slide. Now, as Carolyn rightly pointed out, we went into this first round of measures knowing that there was going to be some amount of refinement and revision. Now, we didn't want to necessarily move things wholesale, but we knew that only until we took it out on the road and really test drove it would we be able to understand and appreciate where we had resonance and where we did not. And we initially started at 41 measures in the initial set, and we've now got a nice consolidated streamlined measure of 35 measures, many of which stayed, but some of which we'll talk about in more detail, we changed, we removed, or we refined in some important ways. Now, first, the criteria of how we made decisions about revising or refining measures. We wanted to make sure, revisiting some of our initial analyses, which did look at measurement validity and construct validity and these types of things, we went back through and really held it to an even additional review and standard and said, does it really match up to where we want to be in terms of the quality of the measure, the quality of the data collection? We needed it to have enough of a research underpinning conceptually where we could at least link in a primary or secondary way to a health outcome, and we revisited some of that research and analysis that we did at the outset. We wanted to make sure stakeholders really felt like it resonated as a measure, that it spoke to and was representative of the particular driver that it was linked to within the action area that it was linked to in the action framework. And we didn't want things to be altered in such a way that we lost sector representation at any part of the measure set within culture of health. If we lost a nod to the business community, that would not be reflective or representative of what we're trying to do in the culture of health measures. And once again, we were able to move and refine things from 41 to 35, which we feel is a nice set that can carry us forward for some time in terms of capturing culture of health progress over time going forward. Next slide. So let me talk about some of the changes and edits that we have put forth by action area. So as a reminder, action area 1 is about making health a shared value. And if you were following our measures closely, you know that we wanted to capture newer forms of data, not simply survey and administrative data, but social and social media data. We had a measure around the conversations on Twitter about how Americans were dialoguing around the use of acute services, how they were conversing and talking about what they were doing with respect to health promotion and more preventive behavior activity. That's still an important measure and is critical, but we felt like that only captured a segment of the audience. We wanted to capture something that we knew was more pervasive in terms of American behavior, which is internet search behavior. And we were able to develop a very nice relationship with Google in order to capture internet searches related to some of the same things that we had in the Twitter measure, but which is around searches for health promoting information. Under the idea that appreciating where people were going for information and how they were looking for information, was it around sickness or was it more around wellness and well-being, would tell us something about the proportion of the dialogue and conversations that people are trying to start having by searching for information on websites that are related to health promotion. It's a piece of understanding shifts in mindset around health and well-being and expectations that people might have that health is not simply about acute or sickness care alone. Next slide. Now in action area 2, this is the fostering cross-sector collaboration to support and cultivate well-being. We have been doing some work to try and understand the investments of a lot of different sectors in health. And one of the ways that we do this is understanding where money is going in terms of health in all policies or health in all decisions. And so one of the measures that we really developed and refined in this round, which we think is important going forward, is to try and understand a little bit more of a slice of what we might call the total spending on health and not simply on healthcare. Well, a lot of that spending is happening through federal agencies, particularly some of the federal executive agencies like the Department of Justice or Housing and Urban Development. And so a RAND team working with some experts externally started to code essentially all of the allocations to programming in these other agencies, these other departments that had a primary mission or objective around health. And that allowed us to capture something a little bit more nuanced than simply what HHS is spending, but to understand where health is represented in programs, where health is represented in budgets of these other agencies, because they have a critical role in influencing and informing social drivers or social determinants of health. So that's a refined and we believe a tighter measure that's represented in action area 2. Next slide. Now in action area 3, we had some measures of the built or physical environment that we know matter for promoting and creating conditions that support health and well-being. And we had some important measurement around complete street policies and the like, and we felt that that was still a critical measure. But we wanted to make sure that we had as much of a robust quality data source for some of that information that could be systematically assessed over time, and also spoke to not simply street connectivity and aspects of complete street policies, but also spoke to aspects of public transport and certainly how walkable a community is. And so we worked with our colleagues at Urban Design for Health to pull in data and analyses that they had done on walkability. And this was very much appreciated because we were able to look at much more nuanced levels nationally at the census tract, at the smaller unit of analyses to understand the distribution of walkability across the country, which we know is distinguished by things like income, rural, urbanicity is a big factor, as well as some aspects around race, ethnicity. And we felt like this would be more sensitive to some of the equity issues that we're trying to capture within a culture of health. Next slide. Now, also in action area 3, we wanted to represent what we know is a critical driver of health and well-being and something that the foundation is very committed to, which is investments in early childhood education and development. Now, we had a measure around early childhood education, but given that we had a little bit more time and we had some newer sources of information, we were able to combine data on preschool or early childhood education enrollment along with information about quality and quality of that education. So if you go on the Culture of Health website, you're able to sort a little bit to look at the overlays of enrollment with quality education data, which we think is important. It's not simply the enrollment, which we know is key, but the access to quality education as well. Next slide. Now, one of the critical components of strengthening health services and to think about the integration of public health, social services, and health is to really think about some of these new structures that are being put in place to improve patient-centered care, to improve payment, to support better value in health services. And one of those is, of course, accountable care organizations, and now the expansion to accountable care communities. And so working with our partners at Levitt Partners, we were able to capture some information on the changing numbers in terms of the presence of accountable care organizations. And this is one element, one indicator within this broader measure area of alternative payment models that are really intended to improve population-based health outcomes. And by including this, it's not the only thing in alternative payment structures, but it gives us an opportunity to strengthen the dialogue and the conversation that we have about how payment structures are linked to everything from value-based purchasing to other aspects of quality healthcare services. And so this is a improved and slightly updated and refined measure. Next slide. One of the measures that we're really excited about is the other new measure. Like walkability, we had 2 new measures that are added into this new grouping of 35 measures. And that's a measure of incarceration. Now, for some time, the team has been engaging with colleagues at the Department of Justice and talking to others who are doing critical work in justice reform and public safety issues. But we felt one of the missing gaps was really reflecting that, particularly as an outcome of a culture of health. With the idea being that in a community and in a country that really values health, well-being, and equity, you would not have the unbelievably high numbers of individuals in this country who are incarcerated. And so this is a measure, a straight measure of incarceration that we're able to get from the Bureau of Justice Statistics, but it's further divided by things like race, ethnicity, which we know are disproportionate in terms of incarceration rates. Incarceration obviously is also related to other aspects of educational and economic outcomes, but is critically important to health and well-being outcomes as well. And so we believe that this opens up a dialogue with some of our colleagues who work in justice system reform and public safety issues overall, and to see that link between health and justice issues. I'm going to now turn over to my colleague Margaret, who's going to continue on.
Thanks, Anita. So thus far, we've provided a refresher on the process of developing the framework, and we've given you some insight into the measures that we've refined and how we've done so. And you've heard throughout that we have done a lot of learning and engagement with different stakeholders. So pausing here to reflect on what we've heard. There have been a few themes that have emerged during the conversations that are really worth reinforcing. The first being that the culture of health vision is ambitious. Lasting improvements in health, well-being, and equity will take time. They'll take a generation, and resources and innovation beyond what the Robert Wood Johnson Foundation can inspire. It has also been clear that it will take innovations from those who may not yet recognize their role promoting health, those who may have been on the outskirts working to improve health, but not yet recognized for the roles that they play. The action framework, as we've said, is a really helpful tool for beginning conversations and for illuminating the different roles that groups and sectors can play. I think Action Area 1 provides an excellent example of this. So health and healthcare organizations are not likely those in communities that may be leading on civic engagement, but community-based organizations are, and they may be encouraging civic engagement by highlighting how it's important for community members to have a voice in decisions about health and well-being. This work is critical to building a culture of health and making health a shared value. We have an ambitious and bold vision, and it will require unprecedented and unconventional collaboration, so we must move forward together. We heard too that there was a lot of opportunity for us to share how different sectors could engage with the framework. This was loud and clear throughout different stakeholder engagement. So along with our RAND colleagues, we put some thought to this and fleshed out examples that we hope are helpful, which you see on this slide. So if we move from left to right, you see examples of sectors, some of the typical roles that these sectors play, and our ideas of how the framework could be helpful. I'll say here that this is one of the resources that we released along with the report and that you'll find on the Culture of Health website. It is certainly not exhaustive. It's intended to inspire. As you review it, as you use the framework in your own daily work, we'd love to know how, and we'd love to build this out to make it even better of a resource. So moving on, we will not see improvements in health and well-being and equity if we don't build the evidence base and if we don't share knowledge. Pictured on this slide are two of the mechanisms the Foundation has supported for doing so. Through our partnership with the journal Health Affairs, we routinely support series of articles. Carolyn mentioned that the first was released in November of 2016, and we've done a few since then. These series of articles are really different sets of research. We hope it's not only illustrative, but also inspiring, so you can review and kind of reflect. The second image is our Knowledge to Action book, which is a kind of a reprise of the Foundation's anthology and includes different perspectives on the innovations that are necessary to accelerate progress in health, well-being, and equity. So we've said all this, and you may have a question of what does progress look like in a culture of health? I think there are three tenets that the RAND team has really helped us to concretize that are worth sharing with you all. So first being that as we progress toward a culture of health, we're likely to see narrative shifts, that there will be changes in national discourse, that we'll have more of a conversation around health and more around well-being. And an example here, we've talked a bit in this webinar about business and their role in health. We see a lot of companies that are focusing not only on improving the well-being of their employees, but also how they have a positive impact on the health of their communities they reside in. This is key to a culture of health for sure. Second, action. It's central to this work. We have an action framework after all. Actions we hope to see as progress include shifts in investments, how resources are allocated is really indicative of where priorities are and where they are not, and also how the workforce does and does not develop to meet changing healthcare needs. We've been excited to see progress around action, early childhood education, and more robust investments at different levels. Third, but not least in importance, we expect to see signs of progress through changes in the way that we measure. And this is certainly work that we hope to inspire by including a set of national measures that draw from different sources and cause reflection on the different ways and different issues that health touches our lives. We think that we'll see change not only in how we measure, but what we measure. And we're starting to see this not only in our measure set, but with the inclusion of health and well-being metrics in other sets. As we conclude, before jumping into questions, we would love to point you to two resources. The first, on the left side of this page, is the full report outlining what we've done to get from the initial set of measures to where we are now. It goes into greater detail about each of the measures, the data that was used, the current value. It has a synthesis of what we've learned, including from specific groups. And it also has this very handy, or we hope to be very handy, tip for users, which you see screenshotted on the right side of this. So this is similar to the earlier slide. It outlines different sectors, the roles that they play, and the different ways that the framework could be helpful, or the different ways that sector could think about an action area. So we certainly encourage you to go and to view and to download and to share widely all of these resources, and they're available at that link at the bottom of the page, and you'll also find them if you go to the Culture of Health website. So now we would like to shift to taking your questions. As a reminder, please use the chat feature, and we hope to get to as many as possible.
And indeed, we do have a couple here for you all. The first question, and I'll give this to Carolyn or Margaret. Can you share an example of how organizations are incorporating the culture of health vision into their work?
I believe the Memphis group that we talked about is one that has used the framework to help them think about different ways in which they can encourage employers to think about the health of their employees and their families. That's one example. We've also had conversations with others, trying to think, in Ohio, the Cleveland group in Ohio, that is using the framework as they put together, this is a health coalition again, as they put together a health coalition across sectors to try and focus in on different health issues in their community. They're really using the framework, and have talked to us about using the framework to think about whether they're focusing action in these different areas and how they might focus action in the different areas. And it's also, it's often helpful, I think, for organizations to look not just at the action areas, but also at the drivers within each action area, because it helps to zero in on some particular areas of action that might be useful. So when you think about fostering cross-sector collaboration to improve health and well-being, that's still a fairly broad space to work in. And so for some organizations that we've talked to, it's been helpful to dig down a little deeper and go to the drivers and think about what they might do in terms of policies, in terms of investments and collaboration, and the other driver in that area is the number and the quality of partnerships.
And we can thank Sarah for letting us know that the work in Cleveland is the Health Improvement Partnership, and they're a focus of the RWJF-supported ARCHES project, which she is part of.
Excellent. We love crowdsourcing the webinar. So second question for you all, how do clean air, clean water, and access to open space for recreation fit into your assessment of a culture of health?
Well, those are all measures that we've identified and highlighted in this. The clean air quality is one of our measures, and the walkability starts to get at that built environment. And I think when you look at the drivers within creating healthier, more equitable communities, we have social and economic environment and physical and built environment conditions. So we see those as very important and reflected both in the structure of the framework as well as in the measures. And I should also just point out that, you know, when we highlight these 35 national measures, we want to make it clear, or we hope it's clear, that we don't think these are the only things that are necessary to build a culture of health. We view these national level measures as illustrative of the drivers that they're in and good points of assessment as we track progress. But these are in no way the only things that are important, and if something is not on here, it doesn't mean that it's not important. These are an illustrative set of measures. And we also want to keep emphasizing to those who might want to use the action framework, the measures, again, were selected to be this illustrative national level set of measures where we're tracking the nation's progress. So, you know, communities and individual organizations are likely not going to, it won't be useful for them to use these particular measures for what they're doing. And again, we would focus back on the action areas and the drivers and measures and data that you might find available that are more relevant for your own work. And remember that the national measures are for a way for us to try and track the nation's progress.
The next question is following up on something you said earlier. Can you please speak more about the federal investment in health in all policies? Is this more about policy that includes health, investment in health at the federal level, both, neither? And is there an interest in promoting a shared understanding of health via common federal definition of health? That's a lot. So.
Yes. Anita, do you want to jump into talk more about that measure?
Yeah, absolutely. I'm happy to, and I appreciate the question. So, first and foremost, the measure area name is Federal Investment in Health and All Policies in order to invite many conversations about indicators and narrative around the shared federal role in health promotion above and beyond what HHS does. This particular measure within that, the indicator that we've selected is essentially a measure that does two things. It codes all of the federal programs through a set of the remaining executive agencies, with the exception of the Department of Defense, the VA, because we felt that was all going to be health focused, but really principally focused on things like DOJ, DOT, HUD, and the like. And all of these departments are listed on the Culture of Health website. You can sort by individual agency. And what we did was we coded the programming, and we noted to the extent to which health was a primary part of a mission statement of a program within that department, or a primary element of an outcome that they were intending to address very explicitly, that they linked to health. That was one. So when you see the allocation or the percentage numbers of programs coded towards health, that's what that indicates. And then we also looked at the total dollars that were being allocated in these budgets towards activities with health being in a primary part of an objective, a mission, or an outcome. And so you can sort in terms of the data on percentage of programs and percentage of budgets. What will be interesting to track over time is how that shifts as federal priorities shift. And it'll give us at least one part of the total story on what we're spending, or at least we're planning to spend on health. Over time, you want to link that beyond just allocations to expenditures. And over time, you want to not just look at federal government spending, but state and local and private spending. And that's part of the puzzle, but this was a very big start. In terms of shared language around the narrative around health, I mean, a lot of these measures, as we've talked about, are not just intended to track progress, but to catalyze dialogue. So what we're trying to do is use these things to invite conversations with federal agencies to say, how are we defining health? Why is this now linked in your primary mission or your objective? And these are conversations that certainly need to continue, and we need to keep having them. But the hope is to at least inspire that conversation to occur, and to really put these other federal agencies squarely in the conversation about health above and beyond what HHS does.
Great, thank you, Anita. Can anyone speak to the way that the culture of health vision is being embraced differently in rural areas versus urban areas?
So I think this is one of the things that we've been able to learn through the Sentinel Community Project, the surveillance project that Carolyn highlighted when talking about our timeline and the efforts underway. And I think what we see in rural areas that we may not see in those that are more urban is perhaps related to how they make health a shared value in the sense of community that tends to be a little bit tighter or perhaps more apparent in the work that we've done. I think you may not see as innovative cross-sector collaborations in rural areas, though I'm sure we stand to be corrected, but from what we've seen, that just doesn't seem to be as innovative as in other areas. I don't know if Carolyn, if you would add anything.
No, I think that's really, it's an interesting question that we will definitely be continuing to look at. One of the things about the Sentinel Community Project is that, as I said, we're going to be following these communities for a few years, and one of the important products that we hope will come out of that is some cross-community type reports. So we're writing individual reports for about each of these communities, a couple different ones. But then what we really want to do is look across all 30 and group them into smaller groups and think, what are we learning about what's happening in these communities? And one of the cross-site reports that we're planning is about rural communities and what is happening in rural communities, and what are some of the common challenges they face, and what are some of the very different challenges that go on that they're facing, given the diversity of rural communities. There are a lot of different types of rural communities that are dealing with a lot of different issues within health and healthcare. And so we hope to learn more about that as we move forward.
So now getting a little bit more general, I have a really good question about sort of the context. A lot has changed in the country since the framework was first released in 2015. In divided times, are you finding that health and shared value of health are areas where people can unify, find common ground, and collaborate toward progress?
Again, great question. And I'll invite Anita and Margaret to jump in too. One of the things that that I would say we are hoping to also learn from is that a few of our measures come from a survey that we've been doing with RAND, or that we did in 2015 for the first time with RAND. It was a very large national probability-based survey of over 10,000 adults, and it was sourced for a few of our measures in the initial set. We are about to field that survey again in a few weeks or months, and I think it will be very interesting to see if we see some differences from 2015 to 2018 in terms of some of the mindsets and expectation type questions that we have in that survey. So we're really looking to see what comes out of that survey. I think that's one source of some information about whether health is still, or health is viewed in a different way than some other social issues, and whether there can be more common ground around providing health or supporting and promoting health for all, and what that means in our society and in the different parts of our society today. But Margaret or Anita, do you want to add something to that?
This is Anita. The only thing I would add to that, and that's a great reference to the survey, and I think people will find some interesting information there, is that as part of the development of the action framework, we tried to engage individuals across the cultural and political spectrum as we were defining action areas and thinking about terminology. And while there's much debate, I think, and continues to be around health insurance and really important critical issues, as we start talking about health promotion or starting to talk about the priority that health places in terms of advancing some of those aspects of social and economic progress, there is a point of connection and opportunities to build consensus that probably have not been exploited as effectively as we could as a country and as a set of communities. And figuring out those points of narrative and language around health promotion and well-being tends to be a point of opportunity. But what has been challenging is sometimes when we talk about health, people immediately go to healthcare alone. And so finding entry points to talk about the broader definition of health and finding points of sharedness is possible, but we just need to spend a lot more time thinking about how we dialogue and the words we use and how we convene. And I think you see that to the earlier question about rural and urban. There are opportunities to have that dialogue, but it might not be how we have talked about health in the past. And so the survey and other things should hopefully give us some more insight, but we welcome every idea possible about the health narrative going forward.
And this is Nicole Bronson. I'm actually a communications officer here at RWJF, and just chiming in to say that the other part of this work that we're doing on the communication side is some message testing, both sort of generally with all of our audiences, but also with specifically rural audiences, specifically conservative-leaning audiences, business leaders, to try to figure out, are there real divides in how we are thinking about these issues, or is it really a question of language? And in a lot of cases, we are finding it's language. When you get down to it, everybody wants to work together toward better health, but there's a divide about how we get there and how we talk about getting there. So we're working with partners on that as well as sort of a corollary to this work. We'll move on. We have about time for maybe one more question. And well, and this relates actually to what we just talked about. Is the idea of a culture of health being embraced consistently in your work that that you've seen? Does it mean one thing to business, something else to housing, and something different to the criminal justice system? And then I'm going to add on there, and if so, if there are different meanings, did that contribute to the way that you changed the measures at all?
Well, I think there are different views of what it means and how it's embraced or understood within different contexts, and I think that's something we expected, and don't we don't have a very precise and rigid path forward. And one of the things we often talk about when we're talking about the action framework is that, we called it a framework, not a model, because we sort of thought of a model as being kind of a blueprint and very prescriptive of how to move forward. And we see this action framework as much more fluid and something that a lot of different people can find their work in, and maybe not find their work in every part of it, but find an entry point into it. And different organizations and sectors and groups can look at this action framework and use it in different kinds of ways to help them think about different parts of it. We have the framework as these 4 interconnected areas surrounding the outcome area, because we do feel like action needs to be taken in all 4 of those areas, and the action that's taken in one feeds into another and feeds back to the one, to the others. But it doesn't mean that everybody who uses the action framework uses it in the same way, uses all of it, or needs to at all. And we didn't think about that. And as we've also tried to convey is, we use the term culture of health, but we really think of this as cultures of health, and people using it in a way that fits with their particular community or group. And for